My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Program in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. Welcome to COVID-19 Clinical Rounds for Critical Care, Life-Saving Treatment and Operations. This is the fourth in the Critical Care series, and last Friday we did an additional fifth special session on ventilation management strategies. The purpose of these rounds are peer-to-peer real-time sharing of critical care challenges and successes in patient care and operations. If I'm an intensive care clinician preparing to care for many COVID-19 patients, the physicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration, and thanks to you and the multiple professional organizations who are collaborating on this. This is not intended to be redundant or replace any organization's initiatives. It's intended to be a sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Our appreciation goes to NETEC, the National Emerging Special Pathogens Training and Education Center, for their support with. And thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform that we're using for these rounds. Upcoming ECHO COVID clinical rounds currently are all US noon Eastern time. Thursday, April 16th, noon Eastern time will be COVID-19 clinical rounds on emergency department, patient care and clinical operations. On Monday, April 20th, noon Eastern time, we will have COVID-19 clinical rounds on EMS patient care and operations. Our planned schedule for the upcoming week will be Monday, EMS, Tuesday, critical care, Thursday's emergency department. When we do send out announcements for upcoming rounds, at times you will not see speakers. They are TBD, to be determined, since we work to identify speakers just in time, given the rapid changes in experience with the pandemic. For the ECHO clinical rounds we've had to date, we've had participants from all states in the United States and many countries, predominantly physicians, nurses, and EMS clinicians, but also respiratory therapists, veterinarians, and others. We received many pages of questions, and we apologize in advance that we're not able to answer all of them. We're very interested in continuing to have this be interactive by engaging expert discussants or panelists who you see up on the screen right now, and we do crowdsourced polling as well. We've picked out a few major themes from the questions we've received and hope to cover some of those. This peer-to-peer learning platform allows us to have speakers and expert discussants who are leaders in their field who are on video. Please also, a reminder to use the polling in the chat room to help us with crowdsource experience. Dr. Struminger, please, if you could do some housekeeping with reference to how these rounds go.
Thank you, Rick. Just sharing, hopefully some slides there. Are you able to see those? Actually, going to do that again. Great. So a few housekeeping items. Again, welcome to everyone for joining this week's clinical care rounds. First is please reserve the Q&A function on Zoom for questions and comments regarding the presentations and the topic focused on critical care. Please reserve the chat function for questions about technical and logistic issues. And we're going to do some crowdsourced questions that we'd love you to respond in the chat about those as well. The slides and a link to the video recording will be shared after the session via email with everyone who registered. Presentations also are linked to the most recent reminder and should have been in the announcement you received for this session. This session is being recorded and your attendance is consent to be recorded, so we thank you for that. There will be CME and continuing professional development credits available through the University of New Mexico. We'll be sharing a link in the chat at the end of the session. And we encourage you to get that CPD, and we really appreciate the feedback we get through the survey that you take. It's anonymous, and it helps us to improve the quality of these sessions. And with that, I'm going to pass the baton to my colleague from the AAMC.
Thank you so much, Dr. Scherminger. I'm Rosha McCoy from the Association of American Medical Colleges, and just wanted to tell you about a resource that's available. The AAMC was asked by a number of academic medical centers to become a central repository for COVID-19 clinical guidance documents. And so we've developed a website that's constantly being updated. We currently have guidance from the University of Washington, as well as Mass General, Emory Healthcare, and University of California in San Francisco, and more coming. And again, we're learning from all of you and continuing to update the site. So we hope this will be of use to you, and encourage you to give us feedback as well. Thank you.
Great, thank you, Dr. McCoy. And back to Rick, Dr. Hunt.
Thank you, Dr. Strominger. We do have the crowdsourcing function. I believe that's through the chat room. And we have 3 questions. And we really do value the feedback we get on these questions. So the first one, what is the most important change in patient care that you've made that has improved outcomes? The most important change in patient care that you've made that's improved outcomes. The second question, in the past 2 weeks, how has your ventilation management strategy changed? If so, how? You can just label that question 2. And then for question 3, what's been your experience with proning patients? These 3 themes have become very obvious to us when we take a look at questions and some of the comments and the discussion that we've had over the past 4 clinical rounds on critical care, and it would be really helpful to get your feedback on these. So with that, I want to introduce our first speaker, and before I do so, I want to give special thanks to the United States Department of Health and Human Services, Office of Global Health, and the German Ministry of Health, who facilitated identifying our first speaker. It's an honor to introduce Professor Clemens Wendtner, the Chief Physician for the Clinic for Hematology, Oncology, Immunology, Palliative Medicine, Infectiology, and Tropical Medicine at the Munich Clinic Schwabing, the academic teaching hospital Ludwig Maximilians University, Munich. With that, thank you, sir, for joining us, and we look forward to your presentation. Thank you.
Yes, thank you very much, Dr. Hunt, also for the invitation to these ECHO clinical rounds. I'm just trying to get my slides started. Yes, I would like to give you some messages from Munich, but also some challenges we can discuss in the next few minutes. So I would like to start, let's see, with this. Okay, I would like to start with our very recent publication in Nature, together with Christian Drosten from the Charité in Berlin. We don't have time to go through all the details of this publication, but I would like to share this slide with you. There are 2 messages you can see. The one is that in the upper respiratory tract of our COVID-19 patients, we do see loads of virus. So we are talking here about 10 to the 9th per ml particles. This is true in almost all patients from nasal and throat swabs. but also from the sputum. And the other message is just look at the x-axis. You do see that we can detect virus up to day 21 and even day 26, 27 in some cases. So up to 3 weeks and even more, we are able to detect virus in our COVID patients. So this gets to the point that first we have to protect ourselves when dealing with these patients on the ICU. And just from a very recent New England Journal publication from the States, from a Boston team, they introduced a so-called aerosol box. We have a very similar tool in practice on our ICUs. We call it a universal mobile protection system. So actually, it's also a plexiglass system. You're just pushing under the bed of the patient, and then when intubating the patient, the physician is quite well protected against aerosols from the patient. So this is based on the evidence that the SARS-CoV-2 virus is also active in aerosols. And again, correspondence in the New England Journal from the National Institute of Allergy and Infectious Diseases in Hamilton. You do see that compared to SARS-CoV-1 in blue, also SARS-CoV-2 in red can be detected in the air of patient rooms. So what is the consequence? You see on the right side, we have a mobile HEPA filter system in the ICU, especially when we are have patients on oxygen high flow systems in order to protect our staff. So we have a very low infectivity rate on our staff members. Now let's move to the patient side. We all know that the main challenge is the respiratory insufficiency in our patients. So we know there is the type L and the type H lung challenge. And so L stands for low elastance, low ventilation perfusion ratio, and the type H for high elastance and high right-left shunt population. You see the pictures, the radiology pictures on the left side. We try to use high flow in cases where we have a type L lung. We try to use the intubation method for sure, so invasive ventilation in the type H lung COVID-19 patients. For high flow, very important that we have also the mouth-nose shield on the patient side. As told, we do use the mobile HEPA system also in the room when we use high flow. And this is also true for the non-invasive ventilation systems. Just hint that we should use also non-vented masks in this system. Again, the mobile HEPA filter system is in the room. Now, when we have to get the patient intubated, so we have to use an invasive system. The tidal volume, sorry for the German expression, but I think it's international, it should be below 6 ml per kick. And we have a PEEP in the range of 8 to 10 centimeters per H2O. So these are the usual systems when we use ventilation in our system, in our patients. So the prone position, there was already the one question. We do see an indication when the Horowitz index is below 200. We are frequently using this in our patients, and you see we use it for 16 hours per day. So it's a long procedure. So we also have staff rotating the patient frequently, and so the position should be 30% high in order to have a prophylaxis against the reflux. And the other thing we also have in use is ECMO. ECMO, the indication is when the Horowitz index is below 80. Otherwise, I think standard procedures here. Now, frequently asked question is about the pharmacotherapy on ICU in COVID-19 patients. The general rule is that we don't use steroids as a standard, as a frequent standard, but there are situations, for example, septic shock, where hydrocortisone is used in the range of 200 milligrams per day. And we also use in very serious ARDS, also prednisolone, 1 to 2 milligrams per kg over 5 days. We use also the iloprost, so we call it Ventavis in Germany, in order to improve oxygenation. So this is one thing we use with the ARONAP system. And finally, discussion also in Germany about the ACE inhibitors, the AT1 blockers. We have a rule, and this is from our internal SOP, not to stop this by routine use. Right now we have a randomized trial running to stop in a 1-to-1 ratio the ACE inhibitors, and they are then for sure substituted by other antihypertensive drugs. Now, I think a challenge in COVID-19 patient is the frequent microthrombotic disease we do see. So this is just from a recent publication from a Chinese group detecting antiphospholipid antibodies in COVID-19 patients. You see very limited data, only 3 patients. But we do see also in our autopsy of our patients, fortunately we only have few patients dying, but in these patients we also have seen microthrombi in lung, in the liver, and other systems. So we do think this is a real problem. And so this communication corresponds to the New England Journal. They have reported about certain parameters. So usually the D dimers are elevated. They have also decreased fibrin, decreased the fibrinogen and elevated degradation products for sure. So these are hints, and they also measured the antibodies, the IgA anti-cardiolipin antibodies that are elevated. So in our SOPs right now, we also measure the D dimers, and so we say when the D dimers are for sure above 5 milligrams per liter, we would use a full anticoagulation procedure for our patients in order to prevent the microthrombi, especially in the lung. Now, another question we are facing is, do we have specific treatments? We are recommending, as you know, there is no in-label treatment, but we're using quite a lot of remdesivir, also on the ICU within trials and also outside of the trials. This is from the very recent compassionate use publication in the New England Journal, showing a 68% clinical benefit rate, so meaning that roughly 50% of the patients could be weaned and could get off the intubation and off the ICU. The median observation time was 18 days, limited observation time, but still. So as you also, most of you are taking part in this 5773 and 5774 trial using remdesivir. The 5773 trial is also open for ICU cases. So having said this, I hope I'm within my time limit of 10 minutes, and I'm happy to answer questions whenever you ask me. Thank you.
Dr. Ventnor, thank you so much for the presentation. I've been anxious to hear from Germany for some time. I think in terms of, if you could move your slide from the screen, then we'll be able to see all the panelists.
Okay. Sorry.
I have, for the panel, I'm going to be queuing this up in just a second for you to ask questions of Dr. Ventnor, but I am intrigued by many of the things that you mentioned, but one phrase that you mentioned, a few patients were dying, and that's a big phrase. It says a lot, and so in a big picture, what do you think has contributed to the high survival rates that you've had? And I know many pieces, but yeah, if you give a sense of why you've had such a high survival rate, I think everyone would love to hear that answer.
Yeah, because I was also exposed to the US medicine during my training, so I know that you guys are doing a perfect job. So I think there are no secrets here in Germany, you know, that we have specific drugs or things like this, or very specific procedures on the ICU. I think the major point is, and that's not your fault, that we realized when we had the first patient here in my center end of January, that this will be a pandemic threat, and so we got prepared. So meaning, for example, in my center, we have more than 600 ICU beds. We have in Germany, we increased the numbers of ICU beds from 30,000 to 60,000. We have doubled the capacities over the last few weeks. And this is the reason, and the other important fact is that we have restrictions in our social lives here in Germany. Probably you have heard about this. So, for example, I'm not allowed to meet friends. I'm only allowed to meet my family here. I'm only allowed to go to the clinic, but not somewhere else in Germany. I'm not allowed to travel abroad and so on. So this is going on for several weeks now. And we do see that the basic reproduction number is now in Bavaria, I can tell you this, is below 1.0. So meaning that one patient is infected less than one other person. And so we have a very gradual increase only of cases right now. So we can easily cope with the situation. I have many open beds. So the fatality rate by this is quite low. I've seen more than 400 COVID patients in my center, and we had 9 deaths so far. So this is the, just to give you a rough idea about the figures here in Germany.
Thank you very much, Dr. Ventnor. One question from the panel. Anyone on the panel have a specific question for, or a big question for Dr. Ventnor? I asked a really big one.
I guess I can ask a question, because with these 9 deaths that you've had, how many of the patients that,
Radu, can you introduce yourself? And
sure.
I should have mentioned that earlier. Yeah, please.
So my name is Radu Postelnik. I'm one of the intensivists over at Bellevue Hospital in New York, where we're currently having a significant patient population as well that's exposed. But Dr. Ventnor, yeah, so my question to you is, you're saying you've had 9 deaths. How many of the patients have you had in your ICUs? Because you said you've had about 600. Do you find a significant portion of them are actually staying out of the ICUs, or how did you get to those numbers?
So right now we have roughly 40% of our cases at the ICU. So this changed, this figure, during the last week. So in the beginning, when you would have asked this question in January to me, I would have told you I had 2 symptomatic cases, and you know the rest 10 cases, they were A or oligosymptomatic. But right now in Germany, we are only you know, taking symptomatic cases in the hospitals. So all the others are in the quarantine at home, and we say 1/3 of these cases sooner or later will end up at the ICU. And so this is also the figure. Right now, we have roughly 40% of cases at the ICU.
Thank you, sir, for your presentation. And with that, I'm going to transition over to our next speaker. Before that, though, I want to go back to the crowdsourcing questions. Excuse me. Number one, what is the most important change in patient care you've made that has improved outcomes? Secondly, in the past 2 weeks, how has your ventilation management strategy changed? And if so, how? And then third, what's been your experience with proning? All right, with that, I'd like to introduce our next speaker. And it's an honor to introduce Dr. Radu Postelniku. He is a critical care physician currently at NYU School of Medicine, where he is the Associate Director of the Medical ICU at Bellevue Hospital Center. He is also the Assistant Program Director for the NYU Pulmonary Critical Care Medicine Fellowship Program. With that, I'll turn this over to Radu. Thank you.
All right, let me pull up the talk quickly. All right. All right, everyone. So thank you for having me. So I just wanted to actually sort of continue talking about what our experience has been here at Bellevue. So my colleague, Dr. Vikram Mukherjee, has been updating the group for over the last few weeks about our preparedness for the pandemic that we've had here in New York and the resources that we used and how we've mobilized teams to get to where we are right now. So I just wanted to start focusing a little bit on, well, what are the next steps for this and for what we're seeing with our patients? And the reason why I bring that up is that we've now, over the last 5 weeks, have seen a significant increase in number of patients, but over the last 3 or 4 days, we're starting to see maybe a plateauing, hopefully a plateauing. And now we have to start asking ourselves, well, what's going to happen to these patients after they leave the ICU, after we've taken care of them, because they're going to have a prolonged course that we really don't know what to anticipate it or how to experience that. So that's what I want to focus on briefly. So just brief to show you where we are right now. So at Bellevue Hospital, so far we've had over 840 COVID positive admissions, about 370 or so discharges, and then 265 of these patients have been in the ICU. We've also been taking other hospital transfers as well into our ICUs since we've had the bandwidth to be able to do that as well. Unlike Dr. Vendner's, our mortality rates are a little bit higher. So of the 265 ICU patients, we've had about 68 deaths, but we've had several wins and several successful extubations over the last 4 to 5 weeks, of which have been about 36 that have gone to the medicine floors, and some of them have gone home as well. Of these patients as well, about 21 or so have been on non-invasive ventilation or high flow nasal cannula in the ICU itself, not necessarily on the floor. And now we've started tracheostomies as well on these patients. And I know you had mentioned a question about self-proning. So I just wanted to I added this to my talk just now, because I think the question of self-proning is interesting. So if you would have asked me this question 4 to 5 weeks ago when this first started, we would say we take everyone into the ICU and we start taking care of them in the ICU early. And what we initially saw, so the way our practice pattern has changed over the last several weeks has been significant. So initially when we had these patients on 4, 5, or 6 liters of nasal cannula, we noticed that if we put them on high flow, they had a rapid progression and they would only stay on high flow for several hours until their respiratory status would decompensate. And those patients would progress to intubations rather quickly. And we were concerned about the exposure at that point for staff, hospital staff specifically. So we were bringing all those patients to the ICU. As our capacity has increased, so now we're at about over 110 ICU patients that we currently have today, we've started keeping more of these patients on the floor. So over the last 2 weeks, what we've started doing is actually having patients who are on nasal cannula or non-rebreather mask actually start self-proning themselves in their hospital beds. We're collecting the data right now to really determine, has this had an impact? Has this decreased the amount of patients that actually come to the ICU and that end up intubated? Have we been able to hold off intubations for these patients because they are self-proning? We don't really have data, and there's not really a lot of great data for that yet. So we're hoping to collect as much as we can. But the concern that we really have now is that as we're starting to see this plateau is that we're noticing obviously that a lot of these patients are on a ventilator for a very, very prolonged period of time, much longer than our typical ARDS patients that we've had in the past. And it's been difficult to wean some of them. As I said, we've had 36 or so extubations, which have been successful, but there's still a significant amount of patients that are intubated or progressing towards tracheostomy, and which will require prolonged ventilator use as well. a lot of our patients are also developing renal failure. And the question is, I think our data right now that we're analyzing very closely is overwhelming majority of them are, our patients are of inner city population, Hispanic background. And we've noticed that there's significantly higher renal failure rates than we have at our colleague institutions as well. Another big issue is the isolation. So as we know that we have no visitor policy at our hospital. So these patients are often by themselves if they're intubated or even if they're on the floors as well. And we're having minimal contact with them. We're only going into the rooms if we need to or as needed or for medication or for rapid evaluation of the patient. A lot of our patients as well are on significant sedation. And by that, what I mean is that they're close to getting maxed out amount of sedation that we're giving them. They're having, especially during when they're having these episodes of what we're labeling as a cytokine surge, or where they're having rapid metabolism of the sedation that they're getting, they're really, really high levels of sedation and sometimes still awake on maximum doses of 2 or 3 sedatives. And they're also requiring a significant amount of neuromuscular blockade to get them to be synchronous with the ventilator. But what's happening at the same time is that those patients aren't really getting any rehab. They're sitting in the ICU beds for a prolonged period of time. And now we're starting to deploy our physical therapists and occupational therapists as well to have some sort of interaction with these patients, because of the fact that we know that these patients who are significantly sedated, have a lot of neuromuscular blockade, some of them have received steroids as well, are at significant risk for having potential complications down the road once they hopefully are able to make it out of the ICU. So the reason I bring up the long-term consequences is that what we've seen in previous data, especially in the sepsis literature and the ARDS literature as well, is that there's significant issues that happen to these patients that we know very well once they're in their ICU. They're going to have neuropsychological impairment, physical impairment as well as health-related quality of life after they leave the hospital. And we're saying, and we're hopeful that we can have a certain patient population leave the hospital. Similarly, we know that patients that are in an ICU setting for a prolonged period of time, especially intubated, they have cognitive impairment no matter what age at 3 months and at 12 months. And this is older data that we've seen and that we're starting to collect now as well, because it'll be interesting to see what's happening with our patient population. So some quick things that we're doing right now for our patients. We're now having this, our social workers and our palliative care specialists are helping us significantly with having video conferences for our patients and patient families, since we're having social distancing in New York City right now. So that means that they're coming by and doing rounds with the patients and patients' families, patients obviously intubated, but at least showing their family and loved one on a video screen to see what's going on, to explain and update exactly what's happening. The question of spontaneous breathing trials and spontaneous awakening trials is a difficult one because they're requiring so much sedation and to be synchronous with the ventilator. We're finding that we haven't been as aggressive as we have in the past with just typical ARDS patients, and we're trying to change that. So that's something that over the last 2 weeks we've been changing. Initially, we were keeping these patients paralyzed very, very heavily and with a lot of sedatives. Now we're slowly changing that strategy. Similarly, I mentioned physical therapy and occupational therapy that we're starting to finally introduce as well to these patients. Tracheostomy. The reason I bring up tracheostomy is that there's some of our colleagues at other institutions are doing very early tracheostomies, as well as others are actually waiting at several weeks after their course of being intubated to do a tracheostomy. Some colleagues are waiting 2, 3, or even 4 weeks. We're starting to place tracheostomies in our patients at about 2 weeks in. So this is where we're going. And we're having our surgical colleagues that are doing the procedures at the bedside. And we're seeing wonderful successes. And as our numbers of ICU patients are increasing, we're now starting to have a significant increase in the amount of tracheostomies as well. So this brings up the question, well, what's going to happen to these patients? What is our sort of their post-ICU and or post-COVID-19 course, if you really want to call it that, going to look like? As we know from previous literature, as I mentioned before, for our ARDS patients, our septic shock patients, they're very high risk of developing post-ICU care syndrome. And this not only affects them, but it also affects their families as well. And this is a significant issue that we often overlook because we're so focused on what's happening in the ICU and we want to recover these patients very quickly, but they're going to have significant impairments many months to years after this. But the question now is, well, is this really just a critical care issue, or does this actually affect the patients that are also on the floor, that are, self-proning on the floor, on high flow nasal cannula, or on a non-rebreather on the floor? This is a completely new disease that's having a huge impact on their daily lives, and we think that there's going to be significant impact in these patients as well. Similarly, what's happening with the healthcare workers? Our system right now is stretched, and where a lot of our workers, everyone is putting in a lot of hours, long hours, either, and also as well self-isolating from their families, some of them. So there's significant risk for burnout and mental health. And we're trying to address this with our psychiatry teams here as well. We're trying to develop ICU group sessions, but really what is going to be the long-term impact of this? And this is something that we're starting to look at as well. And lastly, I bring up our critical care recovery clinics. So some institutions across the US have developed one. We have one here at Bellevue that is rather small, but it's going to expand significantly over the next few months as more and more patients are going to be recovering from this disease. As I mentioned, we know that these patients are going to have significant cognitive function and physical outcomes that we're going to want to study closely. And the first wave of patients we're going to be studying virtually. So that means we're going to do video conferences with these patients and patients' families as well. But we're going to address certain questions that have come up with while they've been hospitalized. One of them is actually anticoagulation. I know this is something that has been posed significantly as well. What's happening with anticoagulation? So we're starting to anticoagulate some of our patients here if we have concerning levels of elevated D-dimers and we have suspicion of PE, because we know that there's these thrombi that develop. But how do we address the anticoagulation question going forward? Is this something that we're going to be able to, do we continue anticoagulating them during the hospitalization, or do we continue anticoagulating them for several weeks after they leave the hospital as well? And do they follow up with us in the critical care recovery clinic to determine, should we stop anticoagulation? Is there a reason to continue anticoagulation? So there's a lot of questions that we have, not a lot of answers yet, unfortunately. And so this is sort of the beginning phases of trying to really put everything together and fully understand what we're doing. So that's it that I have as far as my presentation, but I'm open to questions as we are moving forward from here to see what everyone else has to ask and to share and contribute to this.
Thanks very much, Radu. Yeah, you bring up many questions, many are having, and without definitive answers, this sharing platform is a great opportunity to share thoughts on this. We do have a specific question around tracheostomy from Dr. Jane Carter, a pulmonologist from Brown, who we've pulled into the panel. So Dr. Carter, if you could go off mute and please pose the question.
Thank you very much. And I was very interested that that was on your slide, because at our division meeting yesterday, we were actually beginning to talk about this idea of early tracheostomy, so that we might be able to reduce sedation needs and also to make the spontaneous breathing trials easier. And our surgical group has been quite resistant about that. So could you just comment do you have a selection for who you're trying to go with early tracheostomy yet? And you said that yours is all done at the bedside. I just wanted to confirm that.
Yeah, so all of ours are done at the bedside, or for the most part, if they can tolerate the bedside, which so far has been all of them. The selection criteria have really been patients that have been intubated for at least a week, who are going to essentially have likely a trajectory that's not improving. So their respiratory status is not going in the right direction. Their P2F ratio is still significantly abnormal. And we really don't see that they're going to be able to essentially make it past this 2-week mark, essentially, that we've always used in the past to determine if they're going to need a tracheostomy. And now we are getting at that point. The reason why we're being a little bit more aggressive now is that we are getting to that point where our sedation is, we have less and less supplies of sedatives that we can use. And because all of these patients are using such heavy loads of sedation as well. So then if we can put a tracheostomy in, then we have less resources that we have to stress. But we're still waiting. We're still trying to give all our patients time to see if they turn the corner in a sense. And like I said, we've had several extubations, several successful extubations, and those are sort of our shining lights. This is what we're striving to do, because even though I think a tracheostomy is a wonderful thing, if it can help a patient wean from the ventilator, if we're able to extubate them, then we don't have to really worry about a ventilator at all. So we're very aggressive with trying to extubate if we think a patient is going in the right direction. We've extubated some patients directly to non-invasive ventilation as well. And all of our IC rooms are negative pressure, so that's why we can safely do that there as well. So that's one strategy we're starting to deploy a little bit more now than we weren't using 2-3 weeks ago, which honestly 2-3 weeks ago seems like years ago, because what we've changed from where we were to where we are now.
Thank you.
Thank you both. Dr. Ventnor, there are a couple points made here in the past few minutes. I'd like your opinion on, if you could unmute yourself or your experience with. So Dr. Ventnor, on the issue of tracheostomy, are German intensivists using tracheostomy? Your experience with it, that would be helpful. And then the second piece, let's do that one first, but then the second piece, just before you were able to join, we had a healthy discussion among the group around anticoagulation, the whole microthrombus issue and so forth. So anyway, let's do the tracheostomy first.
Yes. So in answer to your first question, tracheostomy, I think we have a very similar approach than the folks in New York City. So we are trying to use it frequently, to also to get the patients off the ventilator early, at a very early point of time. And so that's a very aggressive strategy we're also pushing. And the second question was about the microthrombolysis strategies, right? So as mentioned during my talk, we are more and more using the full anticoagulation strategy, especially in patients with elevated, also slightly elevated D-dimers. I mean, we do see more bleedings now, that's for sure. But we are very afraid of fulminant microthrombi, especially in the lungs. That is one major reason for deterioration of our ICU patients.
Thank you. Any other comments on the microthrombi challenges from any of the other panelists?
I can weigh in our experience as well, because we've had the similar question where we initially weren't anticoagulating everyone 5 weeks ago when we first started seeing our first patients, and then we had some sudden deaths, and we started questioning exactly what our approach was, and we've started noticing exactly the same thing, that once we see a rapid rise, usually it's interesting, it's been after these patients have these cytokines start, they have this rapid elevation in their D-dimer levels, and then slowly the next day either progress into renal failure or develop some sort of thrombi either in the lower extremity, they go into massive PEs that we've had a few unfortunately as well. So we start anticoagulating prophylactically once their D-dimer level, the level that we've chosen to use, again, this is based on our expert opinion that we've done as a group here, has been if there's a D-dimer level over 3,000 and we have a high suspicion for possible DVT or possible thrombi that are developing. And if there's significantly higher than that, then we start anticoagulating fully as well. But we've also seen some episodes of bleeding. And so there's a very significant risk benefit that we have to use in identifying the appropriate patients for this. And I think we're all a little bit hesitant to fully anticoagulate absolutely every single ICU patient, because there is that risk essentially of bleeding as well. So you have to take a little bit of pause, but from our experience, we've been anticoagulating patients as well.
Thank you. I've got some questions that we've seen in the registration process, and I'm going to go over a few of those and then additional questions that have come in. So, and this is for the whole panel, and actually I'd like to go around and get, you know, it's sort of like state of the art, like where are we today with this? And it's the topic of intubation, and both of you have addressed it, both from Germany and Bellevue. But what we've heard on these rounds now for the past month is an evolution in the approach to intubation. And when I say approach, it's really like, what's the threshold? What are the criteria? And so why don't I'd like to go around, and if you wouldn't mind just introducing yourself, not to the speakers, but the panelists first. Dr. Greedy from Emory, why don't you let us know where you are with the intubation, like what are the criteria threshold at this point?
So we're mostly sticking to our kind of not early, not late kind of strategy. I think we tend still, probably compared to some other places, tend to do it on the early side. But you know, our criteria are basically, you know, when they get to the requiring about 15 liters of heated, not the heated high flow, but the high flow nasal cannula, the humidified one. but if they're progressing to non-rebreather, then they're probably needing to be intubated. If we go to, there are some who are kind of bridging with the heated high flow, like Airvo or Optiva, then we still have defined parameters like once you get to that modality for when you should still be intubated and before they get to like overt failure. So we're kind of doing basically when they get to about if they hit 60 liters or 60% FiO2, and I think in particular it's worth paying attention to respiratory rate because we often focus on oxygenation without really having a good assessment of their ventilation. So they may appear deoxygenating well, but if they're breathing 40 times a minute, then they probably still need to be intubated. So
yeah. Dr. Sullivan, how about your approach?
I think so I'm in Nebraska. We're just kind of ramping up. We're way behind New York, thankfully. But I think what we've seen is a very definite pattern. They go from 2 liters to 5 liters to 10 liters to 15 liters over the course of a few hours. And when we see that pattern, we move almost immediately to intubate and we don't wait around. We don't use non-invasive here. As of right now, we've got plenty of ventilators and we think that that's probably what we're going to try and continue to do. The other thing that we've, at least a few of us have noted is really there seems to be 2 separate phenotypes, if you will. There's those guys who come in and they look like they're a mess. They're breathing 40 times a minute. Their carbon dioxide's up. They're hypoxic, and those guys get intubated right away. And what we've seen, at least it seems to me, those guys end up stiff right away. That's the true ARDS that we've all struggled with over the course of our lives. Then there's those guys who walk in and they look like they should be at a bar having a beer. And they look perfectly normal, and they're not in any distress, and they're just very very normal looking people, but they're hypoxic like nobody's business in the 70s and 60s and 50s. Those are the harder ones, I think, in my opinion, to really make the call, because you're sitting there having a conversation with them, and they're in zero distress, but their oxygen is so low. And so one thing that I've started doing on those patients is I actually bleed in a little Velitri, a little inhaled epoprostenol, because of the thought that they may have some pulmonary hypertension associated with what's going on. I've had some luck with that. At least 2 patients that I've tried that on. We've staved off intubation now for about 48 hours. Those are the patients that, at least in my opinion, when I intubated, we've had 3 or 4 of those now. They don't come every day, but when you intubate them, they have normal peaks, normal plateaus, and effectively normal mechanics. And so I think in those patients, and I don't have any data that would support this, but I think what I'm beginning to feel is that's more maybe of a vascular issue, the microthrombi and so on down the line, but they might be the ones who are more of a vascular issue than a true ARDS, because they're easy to ventilate. At least that's what we found.
Thank you. How about Paul?
Yeah, I don't have that much to add other than saying we lean a little bit early. I think we're still believing in our data so far as showing that there really is lung injury that can be induced with spontaneous breathing. And I think, again, related to the respiratory rate, the more people are working hard to breathe, the more we worry they're making their lung injury worse than if we were to be ventilating them. So that's one of our sort of common triggers is when we see that elevated worker breathing, either as evidenced by effort or the respiratory rate, but otherwise agree with what was said.
What's clear in the past month and listening to intensivists about this and emergency department physicians is the experience with intubation, the timing, et cetera, has changed quite a bit. Now, I would like to hear, Dr. Ventner, in Germany, your colleagues in intensive care medicine, has the approach to intubation from the beginning of this, I think you said your first patient in January, to now, has it changed a lot, or has it stayed the same in terms of like, these are the criteria we use for intubation?
In the beginning, I think we were quite prone to intubation strategies, but we learned that weaning is also very difficult in COVID patients. So we are using more and more high oxygen flow method and the non-invasive ventilation. This works for younger guys, where the ventilation frequency is below 40. I would absolutely agree with my colleagues here. But this is also a challenge for the physicians at the ward, because you get exposed to aerosols, and that's the reason why I pointed out that besides the PPE with whole body suits and so on, I mean, we are using this here in Germany, face shields and so on. We also have this specific HEPA filter system in the room. And using all these protection systems, we have now, I would say, 1/3 of the patients are on high flow, and also a lot of these guys are going back to the normal ward now. So this is a change in our strategy, yes.
Yeah, and for everyone, reference the clinical rounds, we had the special session on ventilation management strategies. I referred that to you. It was in the announcement, as in one of the ones that we've had previously. That was a fascinating discussion about non-invasive ventilation management as a ventilator saving strategy, as it were. And with the ventilator number issue, certainly was one that many were very interested in learning about. I want to move on to a couple other questions. For sure, the one that has, at least to my recollection, Dr. Strominger can correct me if I'm wrong, I don't recall seeing this question pop up before in previous rounds, but the hyperbaric oxygen and COVID-19. Anybody on the panel with any experience or opinions about it? So facial expressions say everything.
We have not tried.
We haven't tried it, and I don't know how you could logistically do it.
All right, I think we'll move right along to another question. It was like, okay, well, we'll see. So another question that has popped up is the convalescent plasma transfusion experiences. Anyone with any experience with that or opinions, thoughts on that?
We haven't used it yet. I know it's very, very complicated. It's not as simple as just taking blood from one person, spitting the plasma and giving it to the next. I think it may have its role, but again, like most of the therapeutics that we have, I think it needs to be studied and studied well before we use it in mass.
Clemens and then Mark.
Same here in Germany, in Munich. So we are getting prepared for this. So we had a lot of discussions during the last few days with transfusion medicine here. So one discussion point was when to collect. So at an earlier point of time or later point of time, we have data, they also published in the Nature paper, that after 14 days, we have a 100% rate of neutralizing antibodies in our patients. So seems to be a quite early event. So arguing for early collection also for COVID survivors for antibodies. But I would agree with the previous speaker that it's a very time-consuming and complicated procedure. Collecting, we calculated we have to collect 660 ml for the donor, and so it's our last line therapy. So we would not use it in a very early point of time. So there are other methods, even experimental antivirals we are using at intensive care unit. I mentioned the remdesivir, for example. So I
Right.
think this is our preferred choice.
There's another question that goes back to a specific question that goes back to ventilation management. One that popped up in the question and answer piece. Last week on the rounds, someone discussed people who presented looking well, but with hypoxemia and atelectasis and could potentially benefit from BiPAP. Is this being seen by others on the panel, and your strategies to address that?
So I can speak briefly to that. So we've had some patients that we've actually put on CPAP instead of BiPAP, actually because it's more hypoxemic. We haven't seen a lot of hypercapnic episodes with these patients. So we've had some patients that we just transitioned onto CPAP itself and have done relatively well, possibly staved off some intubations. And we've had some patients that we've kept on high flow, like I was mentioning earlier, even though the pressure is very little. But those patients were self-proning that we've had on the floor.
Thanks. This one's a really quick one. And I'll just go around, okay? So you all unmute yourselves because it's a question about IL-6 inhibitors. Is anybody using IL-6 inhibitor therapy? And what's your experience with it? Radu?
So we've been using it. We've been using it in select cases. So we haven't been giving it to absolutely everyone just because it is pretty potent, and we've been, these patients can sometimes be septic as well, although we haven't seen a significant amount of it. So we've been using it mainly in our patients that don't have a lot of comorbidities, that are earlier on in their disease process and that have had a rapid progression in their disease. Those are the ones that we've identified, and we've had some of the handful of patients that we've given it to, we've had good outcomes. But again, it's not an en masse data set that we have for that. We have been using remdesivir as well as Dr. Bendner. We're in a trial site right now, so we're enrolling patients for that study as well.
Dr. Bendner?
Yes, so we have few cases in Germany that have been treated with the tocilizumab and also some successes. Problems, I mean, for sure, PCT has to be negative when using tocilizumab. Right now, a randomized trial is initiated for the use of tocilizumab at the ICU.
Thank you. Mark?
Yeah, I was kind of wanting to comment earlier on with the convalescent therapy that all these things seem to kind of share a theme. We actually get like kind of very strong demands from families to use because they've read all this on the internet.
Yeah.
And it's been very hard to triage who it's going to be beneficial to. They're not benign therapies, any of them. So I think that's been really hard to explain to people, is that, we could be hurting them in addition. So we've used IL-6 a couple times, mostly for all of these, it's been somewhat rescue therapy because and that's in the face of a lot of opposition from the families. But, we also just don't have enough to give everybody. So it has not made things easier. So,
yeah, thank you. And Dr. Benninger just had to sign off, but he said that they were embarking on a randomized controlled trial on it. So James?
We are not using it currently.
Okay, great. I have one last question for the panelists. And it goes to the challenge of this being like a really long haul, and the challenges with mental health and just caring for yourselves as intensivists while this has gone on for months in some cases, and will go on for many months to come. So as this has evolved, is there a specific thing that you think is really helpful with just taking care of yourselves as intensivists that are seeing literally hundreds of patients now? Radu?
Yeah, I think that's for us, we want to be at the hospital all the time, and it's been very difficult to be here and also have a personal and family life as well. It's trying to find a very hard to find balance as well to focus on your health, your mental health, your team health. And what we worry a lot about is not only us, but we have a lot of house staff that's involved in patient care. We have a lot of ancillary staff as well. And, initially when we've had a lot of poor outcomes back to back, which sometimes happen, or patients getting intubated, 3 patients in an hour, it takes a huge toll on the staff that's involved with this. And it's a very difficult situation, one that's going to draw out for many, many weeks, and one that we have to be cognizant of and try to address earlier on. And that's why we're trying to have our psychology colleagues help us out, and we're having mental health sessions for our staff here, especially after we've had some horrible events. So we're trying to stave that off, but we have to see in what direction we're going to go in the next few months.
Thank you. Clemens?
Very similar experience. So I think it's very important also to change the teams after a while, so that teams get refreshed. If you have the resources, that's important. Psychology is also involved. The crisis intervention team, very important. But you also need sometimes a weekend off, to get a break, and because that's a marathon. It's not a short distance run we are facing.
Thank you. James?
I think the biggest thing, like I said, we're just ramping up. We got the first patients off of the boat about 7 weeks ago, but in terms of community spread and hospitalizations, we're just ramping up at this point in time. So we really haven't had the experience that most of you have had. But I think the one thing that I could say is that the understanding is we're all in it together. So even as a physician, sometimes you help the nurses do nursing cares because that's what's needed at a certain point in time. That's how we work in the biocontainment unit here. Basically, it's all hands on deck all the time. And I think if you can do that and you get the understanding that you're all in it together, it's going to be bad. Outcomes here are going to be completely different than we're used to having. ICU care is 30-40% mortality in sepsis, and we all accept that. This is not that, and even the good outcomes can be really bad. So I think you have to have that conversation. You have to understand where the trajectory is. You have to understand real expectations and not what you're used to. But at the end of the day, the understanding that we're all in it together, even at 3 o'clock in the morning, that's where we're going. But like I said, I do not have the experience that New York does. We have a lot of theory and a lot of teamwork that we've put into this because of the biocontainment unit. But it's our turn now, and we'll step up and take care of things.
Thanks. Mark?
Sorry. I think, if I could add a little something different, that I think one of the harder things is that, we found that there were kind of a handful of people who ended up being involved in everything, myself being one of them. Not that I'm sad to be doing this, but, it's easy for the handful of people who kind of take the leadership positions to, you have to delegate. And set up structures that kind of allow the workload to be distributed a bit. I think that's really hard for a lot of us to let go of that. It is for me to let go of a lot of that. But the sooner you kind of set it up, the better off you'll all be.
Yeah, thank you. I'm thinking that in our professional societies, our work-life balance lectures in future society meetings will be a little bit different than they had been before. Before I close, Dr. Strominger, any housekeeping things that we need to take care of before we close?
Just to thank our speakers and panelists and everyone who attended, and remind everyone, please take advantage of the CME opportunity and give us your feedback so we can keep improving these. Thanks, everyone.
Thanks, Dr. Strominger. And as we close, a reminder, the next clinical rounds will be emergency department rounds on Thursday, and then Monday EMS, and Tuesday another critical care rounds. And I want to close by reading an email that I received from head of a division in the Federal Ministry of Health for the country of Germany. And it strikes me this is like totally the spirit of these rounds and what we're all trying to do as a globe. We wish the clinical rounds every success and believe strongly in the power of cooperation in the fight against this virus. And I want to special thank our colleague at Bellevue, the panelists, and Dr. Ventnor, thank you so much for sharing your time, your experience with us. We value the international collaboration deeply. With that, thank you so much all, and we'll see you on the next rounds. Bye.